Welcome to this NephroTube online lecture. We'll discuss anticoagulation for hemodialysis procedure. I want to announce that after I finish discussion of all the chapters of my book NephroTube Synopsis of Conventional Hemodialysis, I will publish an online exam covering all parts of hemodialysis. So prepare yourself well. In the description of this video in YouTube, below the video, you will find some important links. The first link is a link to this same lecture, but in Arabic language, for those who like to watch the lecture in Arabic. You will find also a link to the playlist of video lectures about this book. You will find the link for the English playlist and Arabic playlist. You will find link to download this book for free. You will find link to download the PDF of this lecture for free if you like to use it. You will find the link for my website NephroTube, nephrotube.com, where you will find more lectures about nephrology than hemodialysis lectures. And finally, you will find a link to NephroTube social media accounts, the WhatsApp group, the Telegram channel, the Facebook group. You can join us to be always updated by the activities of NephroTube. And finally, it's better to subscribe to our channel and to make the notifications on from our channel, so you will be notified once we upload new lectures. At a start, I want to show you the well-known intrinsic and extrinsic pathways that lead at the end to the formation of blood clot. Our dialyzers that we use in hemodialysis usually activate the intrinsic pathway. So when blood comes in contact with dialyzers, it will form blood clots, and the dialyzer will be clotted. That's why we have to use anticoagulants to prevent the clotting of the dialyzer and the blood lines. So while I'm discussing now this chapter, I will tell you that we will use some anti-factor 10 drugs. Some drugs will inhibit factor 10, some drugs will inhibit thrombin, and so on. So this is my talk outline. I will start by heparin anticoagulation. I will go through all its points. Then I will cover other methods for prevention of blood clotting due to hemodialysis procedure. We are afraid of blood clotting because clotting of the dialyzer fibers also may lead to underdialysis, as we mentioned before in the lecture of dialysis adequacy. That's why we have to use different anticoagulation methods. The first one is heparin anticoagulation. We have two types of heparin that can be used: the unfractionated heparin and the low molecular weight heparin. I will start by details about unfractionated heparin. Let's start by mechanism of unfractionated heparin of action. What is the mechanism of action of unfractionated heparin anticoagulant? This is the unfractionated heparin. It binds to antithrombin, forming this complex between unfractionated heparin and antithrombin. Then it binds to factor 10, causing its inactivation, and to thrombin, causing its inactivation. So what are the doses of heparin that can be used for anticoagulation during hemodialysis? There are multiple methods or protocols for anticoagulation during hemodialysis, but I mentioned in my book the most commonly used methods. Let's say the main idea of each method, then we will go in depth through each method. Method A: you can give initial bolus of heparin, then this is followed by constant infusion. Method 2: give initial bolus, then this is followed by only single heparin dose. Method 3: give routine heparin initial bolus, then this is followed by repeated heparin boluses. Then the next point, the next method is to give routine heparin initial bolus and not followed by any boluses. Before going through each method of them, I want to mention that it's better to administer the initial bolus of heparin through the venous part of the axis of the patient. I mean to inject the heparin directly through the patient. Then flush the venous axis with saline and wait for 3 to 5 minutes till the patient's blood is anticoagulated. It is not preferred to administer heparin through the arterial line, because of if you did that, the non-heparinized blood coming out from the patient will pass first through the dialyzer till the anticoagulated blood reaches the vascular system or the patient body. So if you infusate the heparin into the arterial line, some blood will come out from the patient without anticoagulation, and this blood will pass through the extracorporeal circuit and the dialyzer, and they may cause some clotting till the anticoagulated blood reaches to the patient and cause anticoagulation of the patient's body. Let's start by method A. In method A, you can give an initial bolus of 2000 international unit followed by a constant infusion of 1200 international unit per hour, or you can give initial bolus of 75 to 100 international unit per kilogram followed by 700 to 750 international unit per hour. It's important to know that you have to stop heparin infusion 1 hour before the end of dialysis. This is to reach the desired clotting time at the termination of the session. And I will talk in the coming slides about what is the desired clotting time at the termination of the hemodialysis session. Regarding the other methods, all these methods you have to give initial bolus, one of them followed by single heparin dose, one of them is followed by repeated heparin boluses, and one of them is not followed by any boluses. Regarding method B, you can give an initial bolus of 4000 international unit, followed by 1000 to 2000 international bolus if necessary, according to the filter, the dialyzer shape, is it clotted or not. Method C is to give 2000 international unit, followed by 1000 international bolus at the start of second, third, or fourth hour, and fourth hour, at the start of second, third, and fourth hour of dialysis, and this is very common in Egypt. The last method, method D, is to give an initial bolus of 2000 followed by no repeated doses. In these methods B and C, where you will give boluses after the initial bolus, it is important to mention again that the last bolus must be at least 1 hour before the end of the dialysis session to reach the desired clotting time at the termination of the dialysis session. Okay, coming to the last point in the unfractionated heparin, which is how to monitor unfractionated heparin efficacy and what is the unfractionated heparin antidote. To monitor the efficacy of unfractionated heparin, you can measure the activated partial thromboplastin clotting time and the activated clotting time. We have targets during the hemodialysis session itself and targets at the end of the dialysis session. But actually in clinical practice, the monitoring of unfractionated heparin efficacy is not done by these tests, but the unfractionated heparin effectiveness is assessed by inspecting the dialyzer and the drip chambers for any signs of clotting. So usually in practice we don't do any of these tests. We just inspect the dialyzer and the venous drip chambers for any signs of clotting, and I will mention later in this study that later in this lecture, what are the signs of clotting. Regarding the antidote, the reversal of unfractionated heparin can be done by the use of protamine sulfate. Coming to the next type of heparin, which is low molecular weight heparin, I will go through the same items as I did in unfractionated heparin. First of all, what is the mechanism of action of low molecular weight? Low molecular weight binds also to antithrombin, forming the complex which will bind to activated factor 10 and inhibit it. So low molecular weight inhibits factor 10, but unfractionated heparin inhibits both factor 10 and thrombin. Regarding the doses of low molecular weight heparin, it is important to mention at first that low molecular weight heparin has long half-life. Its half-life is longer than that of unfractionated heparin. That's why it is enough, if you will use low molecular weight heparin, it is enough to give a single bolus at the start of the dialysis. Only single bolus if you will dialyze your patient only for 4 hours. And these are the different low molecular weight heparin and their bolus initial dose. You can read them easily. So, how to monitor the effect of low molecular weight heparin, and what is the low molecular weight heparin antidote? Theoretically, the effectiveness of low molecular weight heparin is determined by measuring anti-factor 10 activity, and this is not commonly available. And even if it is commonly available, the case in low molecular weight heparin is the same as in the case of unfractionated heparin, that in practice, we don't do any lab tests for monitoring the efficacy of heparin during dialysis, but we just inspect the dialyzer and the drip chambers for any signs of clotting that I will mention later. Regarding the antidote of low molecular weight heparin, we all know that low molecular weight heparin has no antidote. Okay, we discussed now the different two types of heparin, which are the unfractionated heparin and the low molecular weight heparin. Now we can ask ourselves which is better to be used, unfractionated heparin or low molecular weight heparin. Actually, from the pharmacological point of view, the low molecular weight heparin has a longer half-life, more rapid onset of action, higher bioavailability, and more predictable effects than unfractionated heparin. And some complications, I will mention later in the coming slides, that the complications of heparin, some of these complications are less frequent with low molecular weight heparin than unfractionated heparin. But actually, the most important 2 points for us regarding heparinization is the bleeding risk and the clotting risk. So, is there a difference in the bleeding risk or clotting risk if I gave my patient unfractionated heparin or low molecular weight heparin? The answer is no. There is no significant difference between both regarding these two important parameters. That's why, because low molecular weight heparin is very expensive and has generally not been found to superior to unfractionated heparin because they have the same risk regarding bleeding and thrombosis. Unfractionated heparin is widely used. And usually most of the guidelines recommend at first to use unfractionated heparin, maybe except the European Renal Practice Guidelines may mention that the first line to be used is low molecular weight heparin. The next point is an important practical point, which is how to give heparin, or what is the heparin dose in hemodialysis patient who is already on oral anticoagulants or antiplatelets for another disease. Say you have a patient on warfarin for a cardiovascular cause or vascular cause, your patient is on aspirin or antiplatelet agent, so what is the recommended heparin dose in these patients? Okay, in patients taking coumarin, if the INR is less than 2.5, so this patient is still in need for anticoagulation during dialysis. But if the INR is more than 3, as in patients with metallic heart valves, these patients don't require heparin during hemodialysis. Regarding aspirin and other antiplatelet medications, these patients are in need to receive heparin anticoagulation during hemodialysis, but take care if the patient platelets is less than 50,000, so you have to stop heparin or decrease its dose, but it's better to stop it. What about new oral anticoagulants, the NOACs? The new oral as apixaban and its family. Actually, there is no available data about how to use heparin for hemodialysis anticoagulation in these patients, but caution is recommended. From my point of view, I suggest that you can dialyze these patients. Start by dialyzing this patient without anticoagulants. If there, try to use the heparin-free dialysis in these patients that I will mention later in the next slides. If the patient's extracorporeal circuit and dialyzer have been clotted, you can give an initial bolus. If there is still clotting, you can give frequent boluses after that. This is my point of view. Okay, what are complications of heparinization? Whatever the unfractionated or low molecular weight heparin. We have a lot of complications. Bleeding, that I will talk about it now in details. Heparin-induced thrombocytopenia, I will talk about it also. Lipid disorders, increased triglyceride level and low HDL, and this is less common with low molecular weight heparin. We mentioned before that some of the complications of heparinization are less with low molecular weight heparin than unfractionated heparin. Osteoporosis also less with unfractionated heparin. Hyperkalemia, because heparin induce suppression of aldosterone synthesis, and this is less with low molecular weight heparin. Pruritus, alopecia, and maybe anaphylactoid reaction, which is called first use syndrome. Regarding bleeding, if your patient post-dialysis needle puncture site has prolonged bleeding, when you remove the needles from the patient, there is prolonged bleeding, and the fistula doesn't clot rapidly. Yes, you can blame heparin and you can re-evaluate the dose of heparin in this patient, but you have to put in mind that there are other causes of prolonged bleeding after dialysis not related to the heparin. You may be giving the patient the correct dose of heparin, but there are other causes that cause prolonged bleeding after dialysis, as outflow stenosis. You have to evaluate vascular access for the possibility of outflow stenosis, and we will discuss how to evaluate the vascular access of the patient later in the vascular access lectures. Evaluate the needle insertion technique and that the nurse in your unit insertion technique is correct, and that the nurses are not causing trauma to the fistula or whatever. And finally, recheck, double check if your patient is on oral anticoagulants. Regarding heparin-induced thrombocytopenia, where the platelets go down after heparin exposure, this is more common with unfractionated heparin, but there is cross-reactive antibodies between low molecular weight heparin and unfractionated heparin. That's why if the patient caught heparin-induced thrombocytopenia while using unfractionated heparin, you cannot replace it with low molecular weight heparin. We have two types of heparin-induced thrombocytopenia, HIT1 and HIT2. What is the difference? What are the differences between them? First of all, HIT2 is clinically significant condition with thrombocytopenia and maybe clots in different vascular systems. While type 1 is mild, transient, and self-limited thrombocytopenia, and it usually occurs within the first 2 days of unfractionated heparin exposure. Type 2 is due to antibodies to the platelet factor 4, which is complexed to unfractionated heparin. While type 1, there is no immune activation, there is no antibodies, it's just platelet aggregation. And by the way, heparin can induce platelet aggregation, and this is one of the pitfalls of heparin. Heparin can cause platelet aggregation and thrombocytopenia, but in HIT1 it is non-immune. Finally, in type 2, you have to use non-heparin strategy for anticoagulation and non-heparin catheter lock if the patient is dialyzing from catheter. But in type 1, you can still use heparin, or if you prefer to use another, it's okay. But no change in dialysis-rated anticoagulation may be used. Finally, what if your patient extracorporeal circuit is still clotting despite anticoagulation? Where is the problem? First of all, what are the signs of clotting during hemodialysis? First, you can find a very dark blood in the circuit. The blood becomes more becomes darker. And by the way, there are other possibilities to find a dark blood in the circuit as hemolysis of the blood, and I'll mention this later in the lectures of complications during hemodialysis. The second, you may find the visible clots in the drip chamber. Here, floating clots, here are clots, or clots in the venous line. Also, as we showed you this picture before in the dialyzer lecture, in the adequacy lecture, you may find that the dialyzer is clotted. First, how you know that the dialyzer is clotted? First, you can find the streaking of blood in the dialyzer. The second, you can find visible clots in the header of the dialyzer. The third, as we mentioned before, if the dialyzer is clotted, you can find increase in the post-pump arterial pressure because of resistance in the dialyzer, and you will find a decrease in venous pressure monitor. And finally, any clotting distal to the venous chamber in the venous line will cause increased venous pressure and post-pump arterial pressure, as we mentioned before in lecture 2 while we were discussing the changes in the extracorporeal blood circuit pressures. So, what if the extracorporeal circuit is still in clotting despite of anticoagulation? First of all, you have to check if there is incorrect heparin administration. For example, if you are using heparin pump and the heparin pump is not working well. Second, reconsider your heparin dose. Third, if you are using slow blood flow, because for example there is a suction from the patient's catheter, so this may be a cause for clotting. Excessive ultrafiltration will cause increased viscosity of the blood and causes clotting. Vascular access problem, if there is inadequate flow from the vascular access, or if there is excessive access recirculation that we mentioned before in the adequacy lecture and we'll mention in details in the vascular access lecture, may be a cause of clotting. If there is kinking of the blood lines, but this is difficult to cause recurrent thrombosis or recurrent clots. Recurrent clots. It will cause clots at least one time. Air trapping inside the dialyzer due to inadequate priming may cause clotting. And finally, if there is multiple interruptions of the dialysis session due to frequent alarms, for example, the patient has non-functioning catheter, which may cause frequent alarms, and the nurse have to stop the machine different times, this may cause blood clotting of the extracorporeal sac. Now, after we finished talking about heparin anticoagulation, what are the different methods to prevent clotting of the extracorporeal sac? We'll start by heparin-free dialysis, dialysis without heparin. When heparin-free dialysis is indicated, it is indicated if there is bleeding disorder of the patient or active bleeding, if there is intracerebral hemorrhage, thrombocytopenia, pericarditis because we are fear from tamponade, or if there is recent surgery. In all of these cases, you cannot give heparin. What are the steps of the procedure which is called heparin-free dialysis? First of all, you have to do heparin rinse. Just rinse the extracorporeal circuit with saline containing from 2,000 to 5,000 units of heparin for each liter of saline. But this point is optional, as it is better to be avoided if the patient has heparin-induced thrombocytopenia, because if the patient has heparin-induced thrombocytopenia, we have to stop giving this patient heparin. So if the patient has heparin-induced thrombocytopenia, what are the other methods to prevent clotting of the patient's circuit and dialyzer? One of them is to use heparin-free dialysis. Then after heparin rinsing, you have to drain off all of this heparin from the line by fresh, non-heparinized saline to avoid infusing this heparin to the patient. Then set your blood flow rate as you want. Then you have to make periodic saline rinse every 15 to 30 minutes according to the dialyzer shape. I mean, according if there is streaking in the dialyzer or not. If there is streaking, you have to increase the frequency of the saline rinse. If not, you can maintain your frequency. The next point of discussion is regional citrate anticoagulation. We have two types of citrate anticoagulation. The first is regional citrate anticoagulation, and the second is local citrate anticoagulation. First of all, how citrate is work as anticoagulant. Citrate binds calcium, and calcium is essential factor for clotting. So when citrate binds calcium, this will prevent the calcium action, and this will block the coagulation cascade. Let's start by regional citrate anticoagulation. Actually, regional citrate anticoagulation is not common to be used during conventional intermittent hemodialysis. It's usually used in the continuous kidney replacement therapy. I don't know any hemodialysis unit in Egypt or outside Egypt that use regional citrate anticoagulation for conventional intermittent hemodialysis. But let's discuss it. Regional citrate anticoagulation itself, there are two types of regional citrate anticoagulation. The first type, which is called the traditional method, and this is the most commonly used. The most commonly used regional citrate anticoagulation type, where citrate is infused in the arterial line before the blood enters the dialyzer. The two types of citrate that can be used, trisodium citrate and 4% citrate solution, but actually trisodium citrate carries high risk of cardiac arrhythmia. That's why it is totally replaced now by 4% saline solution. Okay, so when citrate is infused, it will block the calcium in the blood. So the blood returning to the patient must be infused by calcium to replace the calcium that is inhibited by citrate. And it is important that calcium must be always monitored to know the serum calcium in the lines. Regarding the and another point, very important point, that in this method you have to use calcium-free dialysate, because here you will infuse high volume of calcium, so it's better to use calcium-free dialysate to decrease the calcium load of the patient. The second method, called the modified method. In the modified method, they use the same method, but instead of calcium infusion, they use calcium-containing dialysate without calcium infusion. But actually, I don't know units that use this modified method when they use the regional citrate anticoagulation. Usually, the most commonly used is the traditional method. What are the complications of regional citrate anticoagulation? First of all is calcium disorder. The patient may get hypocalcemic or hypercalcemic. Hypocalcemia because of the calcium citrate complex, and hypercalcemia if the calcium infusion as a replacement entered a high dose of calcium in the patient's blood. Arrhythmia, as we mentioned, hypernatremia if you used hypertonic sodium citrate solution, and this can be avoided by making the citrate solution in aqueous dextrose solution. Metabolic alkalosis because the infused citrate is metabolized in the liver into bicarbonate, and this can be avoided by adjusting the dialysate bicarbonate level on the machine to about 25 milliequivalent per liter. Okay, we talked about heparin and regional citrate anticoagulation. Which is better, or what is the difference between them? Regional citrate anticoagulation is more expensive than heparin and more complicated, more complex. You have to infuse citrate and infuse calcium, and you have to monitor the calcium level of the patient during the hemodialysis session. It is a very complicated procedure. But actually, regional citrate anticoagulation has lower bleeding risk as anticoagulants. Why? Because the regional citrate anticoagulation only anticoagulates the blood in the extracorporeal circuit, while heparin coagulates the blood, regional citrate anticoagulation anticoagulates the blood only in the extracorporeal circuit, because it binds calcium only in the extracorporeal circuit, while heparin anticoagulates both the extracorporeal circuit and the patient's blood. That's why heparin carries a higher risk of bleeding than regional citrate anticoagulation. Regarding efficacy on patency of the circuit, citrate may have similar or better efficacy than heparin. And finally, citrate diminishes complement and neutrophil activation. Heparin induces complement and neutrophil activation as it induces platelet activation, as we mentioned before. So from these points, it's clear that regional citrate anticoagulation is better than heparin, but again, it is not common to be used. Regional citrate anticoagulation is not common to be used for conventional intermittent hemodialysis. The next anticoagulation procedure is local citrate anticoagulation. We mentioned this before in the dialysate lecture. We mentioned before in the dialysate lecture that we have in the A concentrate an acid. And we mentioned that we have two types of acid, acetate and citrate. So if you used citrate in the A concentrate, you are using actually citrate, and this is called local citrate anticoagulation, because citrate in the dialysate will go into the dialyzer and anticoagulate blood in the dialyzer. And we mentioned before here in this table in lecture 4 that citric acid reduces clotting. So using A concentrate with acid citrate will prevent dialyzer clotting, which will increase the dialysis delivery dose and increase also solute transport. Okay, the next anticoagulant method is heparinoids, danaparoid and fundaparinox. Their mechanism of action, danaparoid is directly blocking factor 10, but fundaparinox binds first to antithrombin 3, which will inhibit factor 10. Formed of which, what is the main form of each of them? Fundaparinox is formed of synthetic pentasaccharides, while danaparoid is a mixture of heparin, dermatan, and chondroitin sulfate. Why I mentioned what they are formed of? Because of this point. Which of them can I use in case of heparin-induced thrombocytopenia? I can use fondaparinux because it is formed of pentasaccharides. There is no cross-react with HIT antibodies. But danaparoid, part of it is of heparin. That's why there may be cross-reactivity between danaparoid and the HIT antibodies. It occurs in approximately 10% of cases, so it's better to be avoided in cases of heparin-induced thrombocytopenia. Regarding initial dose, fondaparinux is given in 2.5 to 5 mg. In danaparoid, it is according to body weight, more than 55 kg or less. Regarding maintenance dose, fondaparinux has longer half-life. It doesn't need any maintenance dose, the same case as in low molecular weight heparin, while danaparoid, its dose is adjusted according to anti-factor 10 activity, and again, anti-factor 10 activity is not available, so danaparoid is difficult to be used in hemodialysis patients, although theoretically it can be used. Finally, and it is very important, that the half-life of these two drugs is prolonged in patients with renal failure because they are renally excreted. And this will increase the risk of bleeding. And to monitor their efficacy, you must measure anti-factor 10, which is not available. That's why these drugs may be not popular in cases of hemodialysis. The next point for discussion is direct thrombin inhibitors. Actually, direct thrombin inhibitors are mainly used in patients with heparin-induced thrombocytopenia. They act by directly inhibition of thrombin. They directly inhibit thrombin. The first of them is argatropan. It's given in initial bolus followed by infusion rate. It has to be stopped about 30 minutes before the end of the dialysis session, and the target of PPT is 2 to 0.5 times normal during the dialysis session. But take care that argatropan is metabolized in the liver and cannot be safely used in liver failure patients. The second is lipirodin, recombinant herodin. This is common in Egypt to be used. It is given in a dose of 0.08 to 1 mg per kilogram at the beginning of the dialysis treatment. The target is to have PPT less than 1.5 times normal pre-dialysis, and there is an important point here in lipirodin. Some patients, about a third of the patient, may develop antibodies for herodin, and these antibodies are active antibodies. They increase and enhance the anticoagulation effect of this drug. What are the disadvantages of lipirodin? That it has prolonged half-life in dialysis patients, which may increase the bleeding risk. For sure, it is more expensive than heparin, and it has no antidote. And finally, lipirodin, it is given at infusion rate and can be monitored by PPT to have it 1.5 to 2 times normal during the dialysis session. And finally, other anticoagulants that are not commonly used, the prostacyclin, which is also the prostaglandin I2, and its derivative epoprostenol. It is one of the drugs that inhibits platelet aggregation and adhesion, but actually it is a vasodilator and may cause hypotension. Another drug that inhibits the synthesis of protease inhibitor and doesn't cause hypotension is the nafamostat mesylate, but has other side effects that are reported which prevent its use, as anaphylaxis and hyperkalemia, granulocytosis, and finally heparin-coated dialyzers, where heparin is absorbed to the dialyzer surface, and this in the literature helped to make dialysis, or it allowed dialysis without the use of heparin at all, or at least with the use of reduced heparin levels, but it is not commonly used till now. Thank you for watching this lecture. The coming lectures are about complications of hemodialysis. I will discuss the chapter of complications of hemodialysis in 3 lectures, because it is a large chapter and it contains a lot of details. See you in next lecture, and thank you.